Thank you, Dr. Khanna. Thank you very much. And the anti-hypertensive drugs in prevention management of heart failure. Hypertension is a known risk factor for heart failure, and hypertension is an injurious stimulus to the myocardium by multiple mechanisms. There are changes which occur in the myocardium. Hypertension promotes myocardial hypertrophy, mostly through stretch, neurohumoral activation, and through genes. Either it is concentric hypertrophy, which is much more common, and sometimes eccentric hypertrophy, and quite often apoptosis, which leads to loss of cardiomyocytes. Hypertension through multiple mechanisms also causes macrophage activation, leading to increased synthesis of galactin and ST2, and both these compounds promote formation of extracellular matrix, fibrosis, and capillary rarefaction. The left ventricle hypertrophy, as I said, has two phenotypes in hypertension: concentric hypertrophy and eccentric hypertrophy. Concentric hypertrophy can result finally to eccentric hypertrophy, but usually concentric hypertrophy is associated with HFpEF, and eccentric hypertrophy is associated with heart failure with reduced ejection fraction, as well as heart failure with mid-range ejection fraction. And so all three distinct phenotypes of heart failure do occur in patients who develop hypertension. And the difference between the two heart failures, HFpEF and HFrEF, is HFrEF is characterized by loss of cardiomyocytes, which means apoptosis and pyrotosis probably is dominating. On the other end, in HFpEF, there is stiffening of cardiomyocytes, which means that myocytes are bigger and thicker. I already pointed out that the HFpEF is much more common in hypertension than HFrEF. 25 years back, grades of hypertensive heart disease were described. Essentially, grade 1 means presence of diastolic dysfunction without ventricular hypertrophy, and the last grade 4 is both eccentric hypertrophy and reduced ejection fraction. Patient passed from grade 1 to grade 4 in hypertension as they go on to develop heart failure. So what is the population attributable risk of heart failure by hypertension? Men, 42% of the heart failure in men is as a result of hypertension. 58% of heart failure in women is as a result of hypertension. In elderly individuals, 68% of all heart failures are as a result of hypertension. In India, the data from India suggests that nearly 50% of heart failure patients have hypertension. There is no doubt that there is a big role of aorta, which is a third pump. Aorta gets affected by hypertension, and its stiffness gets increased, and reduced compliance causes ventriculovascular discoupling and promotes heart failure with preserved ejection fraction. Pulmonary vasculature also plays a significant role in hypertensive heart failure. Typically, pure hypertension has hardly any pulmonary artery hypertension prevalence, but in HFpEF, most of the HFpEF, because hypertension, have pulmonary hypertension, indicating that pulmonary vasculature plays a role in hypertension whose pathogenesis involves hypertension. But the left ventricle hypertrophy is not the only denominator of heart failure in hypertension. Hypertension is also characterized by presence of increased diabetes, CKD, coronary artery disease, and all these are also denominators for heart failure in hypertension. In acute heart failure, there is a variety of heart failure called acute vascular heart failure, which is characterized by sudden increase in blood pressure. And acute heart failure, 75% of the acute heart failure patients have some degree of hypertension. Relationship of blood pressure with heart failure is complex, multifactorial, mediated through genes and neurohumoral activation, and is beyond a simplistic framework or afterload indicator. The first study which showed that you can prevent heart failure in hypertensive individual was published 50 years back by Ed Free, and in this VA cooperative study too, it was shown that you can virtually eliminate the occurrence of heart failure by effective therapy of grade 2 and grade 3 hypertension. The recently, few years back, about 10 years back, we had in very elderly patients the study called HIVET. which showed that indapamide either alone or along with perindopril is capable of reducing the chances of hospital or of new onset heart failure by about 65% in elderly individuals. The long-term antihypertensive therapy reduces chances of heart failure by 50%. And that is a very, very impressive prevention of heart failure by simply adequate control of hypertension. The recent study SPRINT has shown that even if you bring down the blood pressure from 140 to 120, you have another 38% reduction in new onset heart failure. And this is impressive. That means as far as possible, try to get the blood pressure as low as possible, possibly closer to 120 rather than closer to 134. So people who have a baseline blood pressure 140 by 90 or below, even those individuals show a relative risk reduction of 12% for every 10 millimeter fall in systolic blood pressure. Which drugs prevent heart failure? Which antihypertensive drugs prevent heart failure? All antihypertensive drugs are known to prevent heart failure. The most effective are diuretics and ACE inhibitors, and least effective are calcium channel blockers and angiotensin receptor blockers. Chlorthalidone actually has been shown to be preventing heart failure far more than hydrochlorothiazide, and this network meta-analysis shows that when you compare the drug-adjusted analysis, chlorthalidone reduces the new onset heart failure by 23% and all cardiac events by 21%. Chlorthalidone is more effective in preventing heart failure compared to all other drugs. And this network meta-analysis again shows that new onset heart failure is 33% less with chlorthalidone compared to a combination of amlodipine, lisinopril, doxazosine, and lisinodipine. Amlodipine, although an effective antihypertensive agent, causes much less reduction in new onset heart failure. And the reason is amlodipine is associated with reflex sympathetic overactivity. As shown in this study, the muscle sympathetic nerve activity increases with amlodipine. So what are the goals of hypertension? What are the goals in hypertension with heart failure? In HFpEF with hypertension, the goal of systolic blood pressure is 120 to 129 and diastolic blood pressure 80 millimeter or less. In HFrEF, you need to maintain a little higher systolic blood pressure, and it will be nice in case systolic blood pressure is between 125 to 140 and diastolic blood pressure is between 80 to 90 millimeter of mercury. The data from recently published Paragon HF study shows that primary endpoints in individuals who have hypertension and HFpEF are lowest if the systolic blood pressure is between 120 to 129. Similarly, in Paradigm HF, the better survival was recorded in HFrEF if systolic blood pressure was above 120. So clearly, there is a difference as far as the threshold of control of blood pressure is concerned between HFpEF and HFrEF. The Copernicus trial showed that people who had a systolic blood pressure above 125 had the best event-free survival in HFrEF, and the worst survival was those who had systolic blood pressure of 85 to 95 millimeter mercury, indicating that in HFrEF you have to be little less liberal as far as blood pressure lowering is concerned in hypertension, and it would be a good idea to keep blood pressure, systolic blood pressure between 125 to 40. Similar kind of data has been shown in this meta-analysis, suggests that there is a J curve in HFpEF as far as systolic blood pressure and diastolic blood pressure concerned, but the J curve is not there in HFrEF as far as systolic blood pressure is concerned, but with diastolic blood pressure it persists. So how should we be treating hypertension in HFrEF? Obviously, class 1 agents in HFrEF equally are antihypertensive drugs. So anti-RAS agents, beta blockers, MRA are class 1 agent for HFrEF with hypertension, besides diuretics, which have a significant role to play. Can I use amlodipine in hypertension with heart failure? The data from a large PRAISE-2 study suggests that amlodipine is not harmful, but it does not reduce the hospitalization for heart failure. Is it associated with little more peripheral edema and more pulmonary edema? And as far as possible, one should avoid amlodipine. Doxazosine also should be avoided in heart failure because it is associated with increase in left ventricle size, increase in BNP, and increased chances of new onset heart failure. Drugs like moxinidine and clonidine also should be avoided in HFrEF individuals because MoxCount data suggests that moxinidine was increasing mortality by 60% at 90 days compared to placebo, and hence these central sympatholytic agents are not a good choice in heart failure patients. Most antihypertensive drugs prevent heart failure and hypertension except moxinidine and clonidine, non-dihydropyridine calcium channel blockers, alpha receptor blockers. So, ladies and gentlemen, to summarize, treatment of hypertension in heart failure is not very different from uncomplicated hypertension. Diuretics remain the mainstay. Beta blockers are compelling indications in HFrEF with hypertension. Calcium channel blockers are to be avoided in HFrEF, and avoid use of alpha blockers, clonidine and moxinidine in heart failure with hypertension. And MRA, which are otherwise step 4 drugs, may be upgraded in HFpEF to class 2 and HFrEF to class 1. Thank you very much.
It was a very excellent presentation.